thank you so much, everyone, for patience and grace as we are all in this virtual world now and learning how different things go every time, usually, at least for me. So thank you for this time frame of grace. I would like to speak on the topic today on expanding reproductive health equity and patient perceptions on sickle cell disease, prenatal genetic screening, and reproductive health. So the conversation will largely be geared toward the ethical implications as it relates to Black women's perceptions of genetic testing, as well as reproductive health more broadly. I have no disclosures to report, but I would like to mention that photos in this presentation may or may not trigger emotional responses. So just working with me here. I do like to include images that center Black women's views and as well as their, presence in medical literature. So the roadmap for this talk, I'll start with a dedication to set the tone of my talk, my research background, some of the results from my data at NIH, current work at Harvard and Ghana, and also my next steps. And then we'll open the floor for Q&A and a panel discussion. So setting the tone, I pose this dedication here. It is a very graphic image of Mary Turner. This is a real photo of an enslaved Black woman. Her name was Mary Turner, and she's the first reported woman who was pregnant while she was lynched. She was 8 months pregnant in 1918. And I show this very graphic image, this horrific image, because it shows how these historical memories still live in the fabric of the reproductive health climate in the United States. These historical memories shape and misshape clinical experiences, and they are embedded in the fabric of structural racism and how it shapes lived experiences of Black women in this country. I also like to mention the hashtag Say Her Name or Speak Her Name. And we speak the name of Henrietta Lacks. As this is Women's History Month, I would like to open this up with the memory of Henrietta Lacks and her contribution toward sickle cell disease. Now, if you know anything about Henrietta Lacks or the HeLa cells, her cells were taken without her informed consent. And they've been used to make so many different treatments and innovations in science, and largely in sickle cell disease as well as it relates to in vitro fertilization as well, and gene mapping, and of course the polio vaccination. So I would like to speak the name of Henrietta Lacks. And in terms of the HeLa cells and scientific innovation, you can see here the orange dot that represents treatment. The HeLa cell gene line was a direct contribution to sickle cell treatments, such as hydroxyurea. So she's often known as or seen as the mother of modern medicine, but I would like to mention that her family is still fighting for, to be seen and to be acknowledged, because so many of the scientists, largely white male scientists, benefited from the historical innovation of her cells and went on to win Nobel Peace Prizes. And while her family still suffers or is still trying to get recognition of this HeLa gene line. So my work focuses on Black women's perceptions of prenatal genetic technology across 3 tiers. And these 3 tiers are often studied in silo, but my challenge was to figure out how we can synergize these different domains. So the first one is prenatal care. The second one is non-invasive prenatal testing. And the third one, of course, is sickle cell disease. So you'll hear me talk through these different topics and intersect them throughout my discussion. So I love to really bring in popular media into how we grapple with maternal and child health and reproductive health in this country. And for me, the face of the hashtag movement really amplified when we learned about Serena Williams' birthing story, right? I'm sure some of you remember when she gave birth in 2017. to her first child, and she attributed her experience to racial discrimination. And so Serena represents of course, Black women in America, but also women of a higher socioeconomic class status, but still experiencing racial discrimination in terms of reproductive health in these clinical experiences. But this is not new, and this did not start necessarily with Serena. This has been such a hegemonic and pervasive topic long before it has kind of become this trend to understand reproductive health and what women have experienced. So in the United States, in regards to the historical roots of reproductive health disparities and genetic technology, I show this caricature, this image here of a Black woman, and she's centered, but she's centered for all the wrong reasons. She's centered for very oppressive and violent reasons. She's also centered with a group of white men staring at her, and they're staring at her because they believe, one, that she is property. In chattel slavery in the United States, Black women were seen as property. Also, two, Black women were seen as, they were also seen as specimens, something to practice science on. So a lot of the innovations in cesarean C-sections and reproductive health were first practiced on Black women's bodies without their informed consent and without anesthesia, under the racist ideology that Black women did not feel pain because Black women weren't human enough to feel pain. Pain was seen as something that is an emotion that only humans felt. And Black women were thought of as property or animalistic or barbarians in that way. So they did not feel pain. And that was the racist ideology that's underlining under this particular caricature. And then you also see her facing forward to see J. Marion Sims. And he's often referred to as the father of gynecology. And I show this because J. Marion Sims is, his statues are like kind of across the US on different college campuses, and it's very controversial. But this also represents some of the historical remnants of eugenics and eugenicism in this country as well. So framing reproductive health equity in the United States, you probably heard the statistic that Black women are 3 to 4 times more likely to die from prenatal complications in the US, and that Black women are susceptible to high-risk prenatal diagnosis due to intersecting structural factors such as racism and sexism, regardless of high or low socioeconomic class status, like in the case of Serena, who is of a high socioeconomic class status, but still experience racial discrimination. And when it comes to sickle cell disease, women are 6 times more likely to die from prenatal difficulties in high-income countries, such as the United States. And these higher prevalencies are due to comorbidities that often are exacerbated by high-risk prenatal diagnosis and sickle cell pain crises. And when it comes to non-invasive prenatal testing, or NIPT, is seen as an emerging reproductive health technology that's been marketed in the US since 2011. It has since transformed the landscape of how they screen for genetic conditions using cell-free DNA. And cell-free DNA is a simple blood test using the maternal plasma, but in that plasma, they're able to screen and detect to see if the fetus has or screens for sickle cell disease without the father's blood as a part of that sample. So solely using the maternal plasma of the mother, they're able to screen using cell-free DNA of the fetus. And now NIPT for sickle cell disease is not yet FDA approved, but it is CLIA approved, and it is in the experimental phase. So we're literally right at the forefront of genetics and genomics when it comes to reproductive health and screening for sickle cell disease in the fetus. So my research question was, what are the patient perceptions of non-invasive prenatal testing for sickle cell disease among Black women with and without sickle cell disease in the United States? And I wanted to ask this question because even though non-invasive prenatal testing is rolling out and rolling forward in the experimental phase and clinical trials are increasing, we really need to understand how Black women are perceiving these genetic technologies, since these technologies will be likely imposed on them, and they will navigate them at prenatal appointments and at the reproductive health clinical encounter. So my team and I, when I was a former postdoctoral fellow at the NIH, we developed this entire study that is one of the first of its kind to investigate or to solely investigate Black women on a very broad level in the United States. This was drawn from narrative medicine or qualitative health approach. And we were roughly in the field for about 8 months virtually during COVID-19. We had a pretty successful response rate. And actually, a lot of our respondents came from SC Red. So we're really grateful for this community and Tiana as well. And so about 40 of the women, among 40 of the women, about 19 had sickle cell, and then about 21 did not have sickle cell, and 4 knowingly had sickle cell trait. Some of the demographics was very broad, and so we wanted to kind of keep it open so that women can self-report on their own demographics that made sense to them. And so we kind of, took some of their demographics on maternal and child health, race and ethnicity as it's self-reported, gender and sexual orientation, and insurance status as a proxy for socioeconomic status. And we also had many other demographics, but I just pulled out a quick few for the sake of this presentation today. So I'll jump right into some of the data because time is finite and we have a beautiful panel coming up right after this talk and presentation. So sickle cell disease as it intersects with prenatal care. So I asked both cohorts, the sickle cell disease group cohort and the non-sickle cell disease group. As a Black woman, do you think there are unique issues you face regarding prenatal care? And of the ratio of participants, 30 said yes. One of the quotes that really stood out was, "This has been problematic for a very long time. It takes more work to be a Black woman. And this is not about treating us different. This is about treating us the same." And so for the sickle cell disease only group, I asked, so how do you feel about reproductive care in this country or in the United States? And some of the words that came up during the conversation, during the interviews, as well as during the in vivo analysis was concerned, frustrated, disappointed, sad, burdened. A respondent mentioned that sickle cell pain is even worse than labor pain. I have a strike against me as a Black person, another strike as a woman, and then sickle cell, the burden and mistreatment during labor and delivery. So let's get into what this means for reproductive genetic technology. I really wanted to pay special attention to the patient perceptions of genetic technology as it relates to sickle cell disease. So here you have some data and results from our study where you have 2 Black women, both have sickle cell disease, both are mothers, yet they have opposing perceptions of the genetic technology. And I show this, and I'll walk you through it in just a second, but I show this because oftentimes in genetic research, as well as maternal and child health research, Black women are kind of grouped together or homogenized into one group. And that really does a disservice because Black women are so variant and have such a wide variety of experiences. And so my goal was to disentangle a lot of the grouping together so that we can actually see that even when Black women have the same, categories or the same demographic, similarities, they might have very different opinions and views on genetic technology. So we see this right here. So I'll read it to you out loud and feel free to follow along. So we have patient number 1 or study participant number 1. She mentions that she's in favor of the genetic technology. She says, "I would want to know, definitely, because sickle cell disease is not something you want to see someone go through. You do not want to see your child go through." And then a mother with the same demographics as her, she had a very different perception of the genetic technology. She said, "What's the point? I mean, what are they trying to achieve? It's going to affect the parents more than anybody. So I'm just curious to know, what is there to gain by the medical world having this information when it's not affecting them directly, it's affecting the parents directly. So the ethical and social implication here is that even though empirical studies on non-invasive prenatal testing often include race, and I put race as a quote unquote variable, this does not mean that they capture the variance in the texture between Black women, between patients within the same racial group regarding the perceptions of these genetic technologies. And this is very, very important when it comes to understanding the ethical considerations of Black women's perceptions in genetics and in genetic technology. And I say this because Black women in the United States are making very serious decisions around genetic technology, but they're making these decisions under constrained social contexts. They're making these decisions under constrained environments a lot of times. And when we do research, we need to be able to disentangle what this means for Black women, but also for women living with sickle cell disease. So here are some other patient quotes that came through the analysis. So theme 1 or T1, you see sickle cell disease in the lived experience. The patient mentions here that being a Black woman, being a Black person with sickle cell, going to a hospital, you're already labeled as a drug seeker, and they look at you a certain way. You can hear it in their voice and in their tone. And then some other quotes about the favorability of the genetic technology. In T2, she mentions, it would be a useful option before more invasive testing. Although because it's predictive, I would have gone for more definitive testing, regardless of what NIPT results were. So this captures the fact that NIPT results are predictive and women are making very serious decisions based on a prediction if the fetus would have sickle cell or screens for sickle cell disease. In T3, another patient mentions that NIPT would be stressful. She says the options are stressful. I wouldn't want to do it. I just want to be able to enjoy my pregnancy, and I definitely would not want further testing. So the word enjoyment really stood out to me because here you have women, you know, grappling with multiple intersections that are often oppressive intersections. But she mentions here that she wants to just enjoy her pregnancy. And that's something that's usually robbed of women who occupy multiple spaces and multiple intersections of oppression. And in T4, the respondent mentions here that she's more of an advocate for midwifery. She says, I wasn't able to do that because I was considered high risk. If there's going to be a situation where a woman who is termed high risk, but she's still going to a traditional OBGYN who doesn't have any experience with sickle cell, then how is that helping? I think to streamline things, have OBGYNs that specialize in sickle cell and high risk pregnancy. So you see that the patient here provided a recommendation because she's interested in midwifery, but because she's high risk, her options become constrained. Her choices for birthing her birthing plan becomes very constrained. And then now she's kind of stuck or navigating between OBGYNs who have very limited experiences with sickle cell disease. So I really wanted to hone in on what that meant and how that it comes up in the data for patients who have to navigate sickle cell disease and treatment thereof, as well as reproductive health, and what this means when you're kind of caught between both disciplines or caught between both situations. And so a patient here, she mentions, and I'll read it to you out loud. He said, I did actually do a consultation with the other doctor that my OB had partnered with, and he allegedly had sickle cell knowledge. But when I sat with him to do the consultation, it was about 5 minutes long. It was literally 5 minutes long. And I asked him, I said, so what do you think I should do differently than a traditional person who's pregnant? And he didn't really have much to share. The only difference was that I came to the doctor more often. There was no different treatment. It was just more monitoring and jumping through extra hoops. And I thought that this was very, very important and very serious because as these genetic technologies are rising and advancing, the current structure does not demonstrate support of sickle cell disease patient knowledge for both providers and patients. And this is a very serious ethical implication for the field. So I wrote about this in a commentary, and you can kind of take the title down here, but it's about trust and how trust also needs to center Black women's reproductive health narratives. And we need to shift away from patient blaming for individual health behaviors in constrained social contexts and shift toward framing structural inequities so that we understand how patients are making these serious decisions under constraints. Now, this poses a challenge, and challenges can be converted into opportunities. But in order to do that, we really have to frame how we're looking and seeing patient perceptions of non-invasive prenatal testing and genetic technology going forward. And this has a lot to do with expanding reproductive equity, but expanding it to be more inclusive of genetic technology as it relates to patient perceptions and Black women with and without sickle cell disease. This really gets at intersectionality and how intersectionality contributes, or if we fail to include intersectionality, this can contribute to structural racism that further contributes to constraint. And how neglecting to understand how Black women are making decisions in constrained social environments, we further constrain their decision makings in regards to fertility, reproductive choices, and births. So the social implication here is that even though a non-invasive test, which is framed as a simple blood test, right? Even though a non-invasive test is considered non-invasive, it can still be a social, psychological, invasive process if the options and the choices are constrained, potentially impacting patient hesitancy and mistrust in genetic technology. So my goal now, as we have this data, is to work on expanding toward more sexual and reproductive health equity worldwide to include persons with genetic conditions. And the reason why this is so serious and so important is that by 2050, the number of people with sickle cell disease is expected to increase by 30% globally. And so I took on the challenge of applying some of the research that we did in the United States to Ghana, West Africa. So I completed my 4D International Global Health Fellowship at Public University, and I'm the founder and principal investigator of the Sickle Cell Women and Girls Project, or the SWAG project. Our research site was at the Ghana Institute of Clinical Genetics, and here are a few of the pictures as well. So why sickle cell women and girls in Ghana? I became very, very adamant and intentional about understanding how female adolescents weigh in on the reproductive health scale. And I started with looking at 13-year-olds up to 25-year-olds. So in the US, my data set started at 18-year-olds to 51. But now we need to get into patient perceptions on an earlier dynamic. So really bringing in more of the adolescent perceptions of reproductive health and in the transition from pediatrics to adult care, intersectional health between reproductive health and sickle cell, and more integrated health between the clinical and the social experiences as well. So I'll just show you real quick as I move through this. Ghana is located in the orange area of the continent of Africa. And then you see these arrows that represent the Atlantic slave trade. And I show this because it's very interesting how not only there was so much movement during that time frame, but also how diseases and illness also moved as well. Because in the next slide, you see sickle cell disease on more of a global scale. So this is also an image from the New England Journal of Medicine in 2015. And it showed in the red newborns born with sickle cell anemia. So you can kind of see the layout on a global scale of the different countries and continents that are severely impacted with sickle cell disease. So this is a global public health issue that needs to be addressed now more than ever. So in the SWAG project, we focused on the integration between sickle cell disease and reproductive health. This is the team that I've been able to train and work with. I had 4 different co-investigators, and I hired and trained 6 different research assistants across hematology, genetic counseling, as well as OBGYN services and clinical psychology. And our methods were roughly the same as it is in the US data, but in Ghana, we focused on two different cohorts split by age. So we had cohort A, which was 13 to 17-year-olds, and then cohort B, which was 18 to 25-year-olds. And we mainly got at more issues about menstruation, birth control, screening of partners, and things of those natures as well. About 24 out of 45 of our patients were also on hydroxyurea. So for the purposes of time, I'm just going to focus on the intersection between pregnancy and sickle cell disease from our patient population in Ghana. And so you see here two different patients who spoke about their experiences, and I'll read them to you out loud. So the first patient, she mentions that pregnancy is a challenge because when I was pregnant, I found it difficult. There was crises here and there. I was short or I lost blood. They gave me blood transfusion so that the pains would go down. And patient number 2 says it was very difficult, or should I say suicidal, because I thought I was going to die. And when she said the word suicidal, that immediately sent an alarm off in my mind and really, really tried to bring in more of the aspects on mental health as it relates to reproductive health and sickle cell disease. So I'll wrap up the Ghana data with this quote here from one of the patients who posed a recommendation for the field. She says, "Because people feel like sickle cell disease is a death sentence, no, it's not. Once you understand, you know how to treat yourself well and how to treat yourself better. So when we have people like that in our community, we know that once a month, a health professional is going to come and give you a speech or talk to us about our condition, what to eat, what not to eat. It helps a lot boost your confidence, and it also makes you less depressed. You know, it gives you that kind of happiness and joy that you have people who are in the same condition as you and who are also thriving. So it boosts you. It also, it helps you also survive as well. So I think that it will help if we have all these group meetings or these people who come around to talk to us, health talks, health professionals who help us with our conditions, because sometimes you can't do it on your own. You will always need someone. And I thought that that was a strong, strong point that she made in terms of the global dynamic, but also in the US situation as well. So we sought to meet that need. We had health workshops and health screenings across our different time points at the clinic. And here are some of the images of our health workshops and health celebrations. We provided menstruation pads, tampons, as well as baby wipes and women's clothes. It was such a magnificent time for the local community as well. And I would love to bring some of that also here to the US space as well. We were also highlighted on World Sickle Cell Day in 2023. And in the center of these photos, you see one of our patients. She agreed to let me show a photo of her infant son, who was also like a part of the journey with us. She was pregnant at the time of the data collection, and now he's going into his, early months of life. So it was very successful for her. And then we were also mentioning the Ghana News for women's health and wellness. So the takeaway of this between the two different data sets, as I mentioned, the data set in the United States that largely focused on expanded reproductive equity for genetic technology, but then also the data set for Ghana that focused on the integration between sickle cell disease and reproductive health. And my critical point here is that we need serious expansion, and that scientific innovation must expand toward reproductive justice to include patient perceptions as told by patients, as told by Black women with and without sickle cell disease worldwide. So I pose 5 different key ethical concerns that I believe the panelists will talk more broadly about. But the first one is in regards to perceptions of reproductive health across wider varieties of women and families. The second one is resistance, framing resistance and hesitancy as a normal process, as a normal part of the process of patients' responses to reproductive genetic technology and gene editing and all of the new trials that's going on, that we have to frame resistance under a clinical context that has been so burdened by structural forces and historical challenges as well. 3, the lived experience is real. The lived experience is legitimate scientific data. And patients who have multiple intersections, such as race and racism, gender-based oppression, illness experiences, have something to say about what's going on with their condition. And that is legitimate and valid enough for us to use the data to help shape policy dynamics. Number 4, listening to patients' recommendations for their optimal reproductive healthcare reform. And then 5, bridging gaps between hematology, genetic counseling, reproductive health providers that work with high-risk pregnancy populations. So for more information, you can check out my recent publication here that focused on patient perceptions on the advancement of non-invasive prenatal testing for sickle cell disease among Black women in the United States. And I really want to thank you genuinely for the time and space to listen through this material. I really want to thank my study participants and the patients that work with me. I'm super indebted to them sharing their experiences with me, as well as my colleagues from the Bonham Lab, NIH, and Ghana, as well as SC-RED and the reproductive health and sickle cell community. So for further connection, whether PR or just conversation, my handles and emails are listed here. And I'd love to open the floor for a conversation and Q&A. Thank you.
Whew. That was incredible. Like, really a striking presentation. I am so proud of you. I remember when you came and you wanted me to disseminate that study, and just to see everything that you've done since, like, it really got me. I don't even know what to say. I knew that we were on the wrong side of this, but seeing you have this in black and white, it just really highlights, like, things are bad. It's such a sense of urgency now. And I really want to thank you for keeping us accountable to recognize that this is not just in the US. Like, this is a global health issue. Wow. So I think that this is so timely. I haven't really shared a lot about it just yet, but SC-RED was called to a meeting at the White House about 2 weeks ago, really in response of everything that was going on in Alabama with the personhood bill. Mm-hmm. And so I just kind of want to get your initial reaction. Like, a lot of times when we see things like the Dobbs decision or what happened in Alabama, we don't necessarily see ourselves in that. Right. Like, can you talk a little bit about how this recent attack on reproductive rights can affect Black women, particularly women with sickle cell?
Yes. So first and foremost, thank you for the space to have these powerful conversations and for the work you're doing with SC-RED. It's so powerful. It literally brought tears to my eyes throughout my data collections to see the work you're doing in the community. So thank you. In terms of the question, I was sitting here just thinking about how New York is also, one of the hospitals in New York has also closed down a lot of the midwifery programs, really impact Black populations. And then Alabama's IVF situation and their bans and policies and laws. It is very, very dark times when we think about how Black women especially are making these decisions, navigating sickle cell disease, navigating comorbidities, and then also having it weigh down on their reproductive health rights and their reproductive autonomy. It is literally violence. And it's violence on the Black body. There's a book by Dorothy Roberts called Killing the Black Body that comes to mind. And then there's another book called Medical Apartheid. And these represent serious cases that Black women have to navigate these aspects, also navigating the mental health of these aspects. So we have to really stop and really acknowledge what this means at the clinical encounter, visibly and invisibly. And so there's a quote that talks a lot about how Black women are largely invisible when it comes to these situations where you see police killings and police brutality that impacts, all of us, of course, but largely Black men. It's much more visible and publicly. But Black women have to bear a burden of the invisible component simultaneously. And not just when it's direct, but also indirect. So there might be a sister, aunt, cousin in Alabama who's, dealing with a fertility issue, who also has to make a decision after post Roe versus Wade, who also has to run the risk of her embryos being not discarded or discarded. And then with that said, the clinicians that she's working with may also feel hesitant to working with her because they might be reprimanded or jailed for some other, instances as well. So it's a very dark time. And I believe that we need much more research, empirical research done on reproductive health as it relates to sickle cell disease on a wide variety. We also need lawmakers, lawyers, genetic technology, genetic counselors to kind of weigh in and for us to kind of help integrate and synergize some of these disciplines. And my last point on that, and I'll stop, is that we need to synergize more. Because what happens in training, in these training programs, doctors and scientists, we're studying one particular specialization or one particular concentration. So you might have a hematologist who's focused on, of course, hematology, or you might have a maternal and child health scientist who's focused on maternal and child health. But what happens is it neglects to understand that patients aren't living these in different bodies, in different disciplines. They're living this in one body. Mm-hmm. They're coming to the clinical encounter in one body that's experiencing both multiple intersections simultaneously. So if we stay stuck in our own disciplines, we will fail patients. We will literally fail our population. So we really need to integrate more. We need to synergize more. We need to come together more, because this is an ethical concern when we have patients navigating serious decisions, but have to go to different providers who don't even understand their conditions.
Wow. I'm so glad that you touched on that. I think I became really aware that this operating in silos is a huge part of why our maternal mortality rates are so high. I mean, obviously other things that you outlined, but like you said, it's going to take everybody coming together. And we do have some plans for how we can be a part of convening everyone together. I'm curious to know, just off of the top of your head, like, what do you think that SC Red could do specifically to kind of bridge some of these gaps?
Well, first, I want to acknowledge what you've already done. And you have already been pillars in the global community as well as in the national community. I know when I was collecting data and we were looking for nonprofits and organizations that focus on the intersection between sickle cell and reproductive health, there were none. Literally, SC Red was the place that we had to go to because you had the intersection spot on. When I was also doing some research on different websites for sickle cell, there's Sickle Cell 101 and Sicklepedia. A lot of those websites don't even talk about prenatal care. They don't even mention what it means to navigate reproductive health, not just for women, but also for men, who are challenged with different types of issues with reproductive health and sickle cell disease simultaneously. So I really want to say that we all need to kind of spread our wings when it comes to SC Red. We also need to support your organization more with more funding, of course.
Amen. Amen.
I want to put that plug out there.
Thank you.
But also, we need to just be much, much more visible. Now more than ever, you see that sickle cell has become, a trending topic, but it's trending because genetic technology and gene editing and the FDA approval that just happened in December 2023 just happened. So it's these genetic technologies and advances are increasing, but the lived experiences of sickle cell disease and the lived experiences of reproductive health are getting worse and they're destabilized. So it's like, as these genetic technologies are advancing, we also need to make the lived conditions better to meet these advances.
Yeah. And I do just want to say that, like, initially when I started, this was just going to be a fertility organization. And had it not been for Kim Smith Whitley, that's all it would have been. But she really opened my eyes to kind of the lack of access to care for pregnant women and the lack of access to genetic testing. And that's how we expanded. And I think that for so long as a community, we've really just had to focus on survival. Like, I say this all the time. But I will say that, like, SCDAA, Sickle Cell 101, they've really embraced us and, like, amplified our mission. And I'm really grateful for that. And then I just want to ask one more thing. What would be your advice to a Black woman, not just a Black woman with sickle cell, but just any Black woman trying to navigate the healthcare system?
That's a very loaded question. Because not only for me am I, of course, a maternal child health scholar, but I'm also a mother. My daughter will be 13 this year. And so I've kind of walked through this in my research, but also just my own lived experiences as well, where I almost lost my child at a clinical encounter out in California. So I remember being over-medicated when I was giving birth, and it really challenged how I saw a lot of what was happening in the clinical experience for me and my personal story. And I never really get a chance to share that. So thank you for asking that question. But I'm here, and this means more to me than just the research. It's a war cry for me.
That was going to be my next question. Like, how did you get into this work? And you just answered, because I was like, I've never seen this before. So wow, that explains. And that's so, I didn't know that about your background in California. Like, we're doing a maternal health event that I need to plug you into out there then. But also, let's talk offline, because I definitely want to make sure that SC Red can partner with, like, swag and support, sponsor, any type of thing. But okay, let me bring up Cass.
It would be so great if we can do something in Ghana with SC Red, because I know World Sickle Cell Day is coming up in June. So if we ever want to take a trip to Ghana to do
I do.
That would be super awesome.
Yes, I would love to.
I can definitely connect some things like that. I don't know if I answered your question as well about advice for Black women, but I think the panel would help carry some of that forward.
Yeah.
I would just say, tell your stories. We need to hear your stories now more than ever. And for me, it's intergenerational stories. It's intergenerational traumas. A lot of us are not even carrying stories and traumas for ourselves. We're carrying it for our foremothers, our foregrandmothers, and aunties who didn't have the voices or the platforms or the everything that's needed to even speak or to have a voice. Yeah. So sometimes I feel when I cry about my research, I'm crying tears for women who may not have been able to cry. I'm feeling what some women may not have been able to feel. And so in a lot of ways, we are on the front lines. So we do have to practice wellness for ourselves. We do have to make sure people honor our boundaries. We do have to tell our stories, of course. And then we also do have to uplift and edify each other. Because when we see each other, then that means that there's an audience connected to that woman and what you see in that woman. And it's really changing humanity. So that's what I would say right now. This is revolutionary to just speak up.
Thank you for saying that. And I totally agree with you. And I thought of you when you were presenting, because I know the tears that I cry at night and kind of the sleepless nights that I have thinking about, like you said, not just me and not just the people right in my circle, the women within my circle, but like when I go to certain events, I'm taking all of the women with me. And so it is heavy and we do have to practice self-care and we'll talk about that. But I'm really excited. This is like a SC Red first because I've never let anyone moderate an SC Red webinar except for me. But Kaz is my girl. Like we are sistered organizations and friends in real life. And so it's like such an honor to be here. Kaz honestly like paved the way as far as a woman with sickle cell leading an organization. And we've seen her impact not just nationally, but globally in the sickle cell community. So it's such an honor to have her. And I'm going to fall back and let Kaz take over.
You can definitely tell we're friends.
I love it. So I'll go ahead and mute, or should I?
Yeah, stay on. I think we can figure out how to loop you in.
Okay. So I'll
I just want to start off and say thank you, Tiana and SC Red, for hosting this important discussion. And thank you, Dr. Thomas, for providing insights on the historical disparities, and the valuable insights that you collected all throughout your research on the lived experiences and pregnancies and sickle cell disease. And I can promise there was a name drop with Sickle Cell 101. I can promise we're working on resources for reproductive health, and we're working closely with SC Red, and it's definitely a gap that needs to be filled. So I'm so happy we're having these conversations, and we can put more of a spotlight on this because it really has become one of those issues that is talked about constantly within the sickle cell community. So as Tiana said, my name is Cassandra Chimna. I'm founder and executive director at Sickle Cell 101. I'm also a person living with sickle cell disease myself, type SS. I'm so excited to moderate this conversation. And I will also admit that although I'm moderating, I also hope to, learn a little bit more about the gaps that people like us face. So I'm moderating, but I'm also listening and learning as well. And so if you hear me asking questions on the side or whatever, don't be mad. I just need some of that information for myself too. So I know this important is this conversation is an important one. So without further ado, we have Wumi here, and I'll let Wumi introduce herself. And then Tiana, are there any other? I just wanted to double check with you. It's the conversation between the four of us, correct?
Yes, we were supposed to have Shawnetta, but she's in a crisis, you guys. So we're praying for her, and it'll just be the four of us.
Okay, that's great. So I will let the fabulous Wumi introduce herself.
Hi, everyone. I'm Wumi Bakare, Director of Comms for Through the Pain, which is another 501c3 nonprofit. And then on the side, I have my little sickle cell prodigy community.
Not little.
We're the little engine that could sidelines. But Dr. Thomas, as you were talking as a West African-born woman, thank you for the work you're doing in Ghana. I have been sick and received healthcare in Ghana. And so I fully recognize the health disparities that exist. But a lot of the work that I do is very important that I think outside the borders, because for me, the United States is not my primary home. Nigeria will always be my home. And so the fact that you have taken your research findings to Ghana and you have found a way to impact community, but also get community voices is very important, because I know, particularly among like women and, their different economic statuses and hierarchy as far as social class. So even getting those women to trust you with this information and share that information with you, I can only imagine how much it took and the force that you are to be able to convince them to trust you and the research that you're doing. So I just wanted to say thank you for sharing all the information that you did. Powerful presentation, and excited to continue to learn from you. And
wow.
T, I will circle back and say this. If you need a bridge between SC Red and the continent, you have people who can be that bridge for the organization. Collaboration is key. You mentioned before, we're all working in a silos. And I think if there's strength in numbers, if we all work together as a collective group, we could move mountains. And so I'm excited to see what we've done in West Africa, but my East African and North African sisters are also requiring your help. So I'm hoping that the work continues with you, but doesn't end with you, that other people, there'll be a ripple effect, and this will become an even greater mission. But that was a roundabout intro. I'm Wumi, everyone. Born with hemoglobin SS, but in 2019, I participated in a stem cell transplant. So now I am just a carrier of the sickle cell trait, but again, still navigating life after transplant. So that's me.
Fantastic. And so I'll go ahead and get started. And I just want to check in with you, Tiana. You'll be joining the conversation and sharing your experience too, right?
Yes.
Okay. Wonderful. All right. Well, I will start off with our first question here. It's for both you, Tiana and Wumi. I guess both of you guys have received transformative therapies. And when I say transformative therapies, think along the lines of, just that one-time intent to cure sickle cell may or may not have worked. I realize that term may need some defining before, just to level set everyone. But this is that one-time therapy to try and cure sickle cell. Please tell us a little bit about your journey from the decision-making to now. And I will have Wumi start off.
Sure. So I think for me, the priority or why I embarked on a transplant was because my health just became a little bit more complicated. As I mentioned before, I have been received medical care in 4 different continents. And so I'm very vast in the disparities in standard of care of sickle cell disease. I came here on a summer vacation for 2 weeks. Fast forward, it's been 9 years, where I just felt really sick. And I genuinely had gotten to a point of saying, I don't think I want to live past 30 if sickle cell is still a part of my life. I will share, and this is just a personal, this doesn't reflect every sickle cell warrior, but I will share that my diagnosis of sickle cell was a little bit more complicated than most I've seen. And so when I came here and initially was given 6 months to live because of the infection I had, I kind of got to that point where I said, there's got to be more to life than sickle cell disease. And so I charted a path less traveled, which is I didn't work with the doctors in Seattle. So my trip was to Seattle and I'm still based in Seattle, but I didn't work with any of the doctors in Seattle. I kind of was a lone wolf and I just reached out to the NIH and say, here's my case. I would like to, if it's remotely possible, consider a curative therapy. And I am Nigerian. I recognize I'm not a US citizen, but is this something that you could open up to someone like me, given my health complications over the years? And I was very grateful that they entertained a conversation. And that was kind of the benchmark of my curative therapy journey. I will highlight and say that I did my research, but there were a lot of conversations that, in my opinion, should have been had and weren't had with regards to fertility preservation and reproductive care. As Dr. Thomas and Tiana mentioned, oftentimes because of the weight of sickle cell disease, we primarily focus on the physical health, ignoring all others, including reproductive health. And so for me, it was just a conversation of, you want to embark on this curative therapy, there's a high likelihood that if you go through chemo and radiation, you will not be able to have kids. And for me, my definition of a happy and fulfilled life included a family of my own and children of my own. And so to be told that, it kind of throws you for a loop, because you're like, okay, here's an answered prayer, but now no one has told me that it's going to impact my reproductive health. And so the conversation was just like, because it's going to impact your reproductive health, you would be required to find someone who would handle fertility preservation in Seattle. It was a very jarring time for me personally and professionally, because there was friction between my family and myself. My family were focused on, we just want you to be alive. We want you to be healthy. And for me, it was, sure, I want to be alive, but I also want to have kids, because I can't imagine a world where I am living without sickle cell, but I can't have the gift that is family. And so I embarked on the journey of fertility preservation by myself. But in Seattle, unfortunately, I met two OBGYNs who weren't the most helpful, weren't the most tactful with how they handled my case. It was more like, you've been on hydroxyurea and other disease-modifying therapies. We don't even think you will have a chance of having children in the future. So maybe just forego your idea of fertility preservation and just delve into the curative therapy process, which for me was, again, that is like someone taking your life and flipping it over. And for me, I always say, I compare myself to a rat. I'll elaborate, because I'm one of those people that I genuinely believe where there's a will, there's a way. And so after the fertility doctors here said they couldn't do anything for me, they had mentioned a certain level, and they said, well, how low your level is, chances of you even having a kid is not. And for me, I wouldn't take no for an answer, because I was like, you're not God. You don't decide that. So what I did instead was I leaned on the NIH and I said, this is important to me. I would like to embark on this journey. And they said, well, have you considered fundraising for fertility preservation? And I'm like, I want to do a transplant. I'm going to need to fundraise for that. And then you want me to tack on wanting to do fertility. Like, that's impossible to just like raise all of that. And I'm sure you guys know it's like between $12,000 to $15,000 just to embark on that process. And so when that couldn't happen for me, I, reached out to my alma mater, reached out to a couple of groups, but I didn't meet the requirements to even get a fertility preservation loan, because I wasn't a US citizen. Number two, it was one of those things where I wasn't married. So how would I finance this as a single woman? There were just so many parameters that I just did not meet at that time. But I then decided, all right, I'm going to go to NIH and start this curative therapy process, because my family, again, as I mentioned, just genuinely wanted me to stay alive. And so upon reaching the NIH, again, I said, I want children. I don't, like, if nothing else matters to me in this process, I want children. And so they then, at the time, were in conversations with a fertility company. And I was one of their first patients that they financed doing fertility preservation. And what was so heartwarming was one appointment with that OBGYN. And it was like, she didn't see through me. She saw me as a woman and my desperation to be a mother in the future. And she said, we'll do whatever it takes. I said, if it's surrogacy, I do not care. Just help me preserve my fertility. And I'm very grateful, because if I had gone by the assessment of the doctors in Seattle, I would not have the opportunity to be a mom today. But upon embarking on fertility preservation, I was able to get 5 viable eggs. Again, after rigorous shots, I think I had to go through rounds of IVS like twice, just so that I could get sufficient amount of eggs to freeze. And so now that dream will likely happen. I hope. Again, everything is in God's hands. But I will say that one of the conversations I wish was had with me was that the probability that when I do have children, I will still pass on the sickle cell trait. Because I understood the transplant process, but I didn't fully realize that they weren't necessarily going to edit my genotype. And so there is that likelihood that my children still could carry or have the sickle cell trait, depending on, of course, who I marry. So that's a little short summary of my personal story with curative therapies and reproductive health.
Thank you so much, Mumi, for sharing that. I'll hand it over to you, Tiana.
Well, yeah. No matter how many times I've heard that story, it's like I still hear something new every time. I did not realize how many similarities there were between us. So I embarked on the haploidentical transplant at age 19. And it was very similar. Like, I just did not want to continue to live my life with this illness. I was constantly sick, feeling like my body was failing, and like watching my friends thrive in college and all of these things that just were not accessible to me at the time. But I did know that there was chemotherapy and at the time full body radiation involved in the protocol. And so I went in to my consult and I literally said, like, look, I'm willing to risk anything to be cured of sickle cell, even death, but I don't want to be infertile. So very similar, like my quality of life was wrapped up in birthing children. And the doctor, this young white doctor, he looked at me and he said, well, to be honest with you, with all the complications you've already had, you're probably already infertile. And so the message was like, you should really just focus on this cure, focus on survival. You can always adopt. And I think that a part of me did kind of reconcile, like, well, maybe it is a fair trade-off. If I'm going to be cured, I'll give up the dream of biological children. I'll just adopt. But, you know, like many of you know, I rejected that transplant. So now infertile, still have sickle cell. But as I've evolved as an advocate, you know, I realized that nobody should have to make that choice. I feel like in oncology, there's access to philanthropic dollars. There's some policies out there. So it's fertility and a cure. But for us, it's fertility or a cure. And that's a huge part of why I started the organization. That was the inspiration behind it, even though we've expanded. One of my highest priorities has remained access to fertility services because I just don't want to see this community have to make that choice. And so a lot of people ask me all the time, like, well, what happened? Were you ever able to preserve? And I actually was not. Actually, something that I've never really shared publicly is that when I finally got in the financial position to preserve my eggs, I didn't get medically cleared for it because with SS, to safely undergo that, you need to be transfused. And I'm alloimmunized, don't have to come off my hydroxyurea. So it just isn't a safe thing. And I feel like the next best thing, though, is SC Red. Like if I can't have it for myself, I'm trying really, really hard to make sure that the next generation and even people in my generation will have access to these services.
Thank you so much, Tiana, for sharing. My next question for the both of you is how has a lack of access to fertility care affected your mental health? You both mentioned, you know, your quality of life being wrapped up in having children. And so both two different outcomes, but what does this feel like, you know, from your point of view, and how has this affected your mental health or your day-to-day?
T, do you want to go or do you want me to go?
Okay, well, I'll go first this time. You know, just like full disclosure, you guys, it's been really, really difficult. It's really honestly a challenge to even get out of bed. I think that, you know, I remember like being in school and looking at all my friends plan their weddings and what their dress is going to look like. And I was not that girl talking about my wedding. I was naming my children. So for a long time, I felt like my identity was really wrapped up in birthing children. And it's something that I've had to work through, but, and I'm not all the way there. Like it's still a pretty sore spot for me, but it's really been an emotional process.
I think for me, I think it's going to be an ongoing emotional process. And I say that because I had really bad friction with my family around the time when I was so desperate to preserve my fertility, and they were so desperate to just have me live. I know I probably didn't speak to any of my family members for like a period of like a month. Wow. All while preparing for the curative therapy, because the only person that had my back was my aunt in the UK. And she was like, I know what that feels like. So I'm not gonna, like, I understand both two things can be correct. You wanting to preserve your fertility and they wanting you to be alive. Those two things can live in the same space. And so now we are working through that as a family. I did get an apology because in that moment, I recognize that when a loved one of yours, a significant member of your family there's a possibility that the person, you could lose them. I know how that can create tunnel vision for different people, and we all react to news differently. And so I respect how they thought through that process, but it doesn't take away the hurt that I had because I felt like I needed them the most. And in those moments, all I had was God and an aunt to just kind of help me navigate that. So that's something I'm still like actively working on. But I'm also in a situation where I am in my mid-30s. I am not married. I do not have kids yet. Again, I recognize that if I did want to have kids now, I'd be classified as a geriatric pregnancy because I'm over 35. But not just that, it's watching the people around me. I'm very blessed to have a niece who's about to be 2 and a nephew who's 5, but it's a recurring reminder of what I don't have. And so even though I know there is the probability that my children could have traits, I'm one of those women that's very adamant, and I will not bring a child into this world with sickle cell disease because I know what that feels like. I know in the community, we all have our different points of view. Some people will say, well, I know what it feels like. So if I birth another warrior, like I'll know how to take care of them. And for me, there is years and years of resentment for my family that I have and I hold on to because for me, my dad has lost 3 siblings to sickle cell. So for me, I always felt you knew better. There's no excuse. You knew better. And so obviously, like, I don't want to carry that with my children. So with that, the way I've chose to cope with that emotional kind of turmoil and push and pull is I sit on a board for a nonprofit called Gift of Adoption, and I do it to kind of channel that hurt so that at least we prioritize adoptions for children with chronic illnesses. And so for me, it's my little way of saying, well, if I get to that point and it doesn't happen for me, I can make it happen for someone else. So I think this is one of those conversations that's relatively sensitive because as women, we are the birthers of life. Mm-hmm. And so having that, looking at yourself in the mirror, it's like a woman who has breast cancer. Someone will say, well, you're in your 60s. Why do you need implants? Is because she attaches that to her womanhood. And so for me, procreation and having children is attached to my womanhood as well. So I think as far as my mental health goes, I've been in therapy for 4 years. Still, every other month, we're still getting checks. And that's just because for me, I like to be more proactive. I don't like things to like hit me all at once before I then seek counseling and things like that. But I think it's an ongoing struggle every day, especially with like social media, where we're inundated with people's perfect lives and perfect families. And then you're saying, well, God, what about me? So I don't really have a well thought out answer, but I hope that answers in its own little way.
No, absolutely. Thank you so much for sharing your perspective on that. I also want to open this up to Dr. Thomas in case she has any questions as well. But I do have a follow-up question for you, Omi. So you had access to preservation, but that doesn't guarantee IVF. And I think you spoke to this a little bit. How does that affect you? And how does that weigh on you?
That is weighing on me more than it did in the past because my clinical trial agreement contract was for 5 years, and August of this year will be my 5th year. So that means all follow-up services will no longer be provided to me. And being that, again, I'm not a U.S. citizen, the reason I've still been here legally is because of medical reasons. And so there is that ongoing worry at the back of my mind that like, post-August, what then happens? What is my life going to look like? But I'm one of those people that has the faith of a mustard seed. So I just feel like God has brought me this far and he will continuously take me further. So in moments where I'm having high anxiety, I think for me, I just say, let go, let God, because it's one of those situations that's genuinely not within my hands or reach.
Thank you so much. And I also want to encourage people who are viewing in, if you are logged into StreamYard, feel free to ask any questions that you have for any one of these lovely ladies here. And I will be sure to answer, or I'll be sure to ask. My question for both of you now is what's next, in your journey and all of this? Where do you guys see yourself in, 5 years from now, 10 years from now?
Well, hopefully with babies. Hopefully with babies. I don't know how they're going to get here. I don't know. But I'm definitely, like, Mumi and I have these conversations all the time. Finally at a place of acceptance where, like, I probably was already going to adopt anyway. I was going to have my, like, birth babies and adopt. And so if all of my children get here via surrogacy or adoption, like, I'll be happy. But I think that I am, like, obsessed with this organization. And sometimes I feel just like Mumi was saying about gift of adoption, like, I think maybe I, like, overcompensate because it just felt so unfair, so nasty that my fertility was taken away from me when I blatantly expressed not wanting that to happen. And so I've been looking for, like, a purpose in that. It just had to mean something. And so for me, starting SC Red is so therapeutic, but it's also, like, a little bit bittersweet, right? Like, I remember when I got the Be the Match partnership and we launched that grant. It's, like, amazing that we've given out 23 grants, but then there's always in the back of my head, like, well, what about me? And why didn't you fight that hard for yourself? So I think that I'm going to continue to push for legislation and philanthropic action to make sure that we have access to fertility, not just for fertility preservation, that's not far enough, but IVF. And while I'm doing that, I'm going to be working on my own family expansion plan.
I love that.
Yeah, I love that.
I could jump into the screen and hug you right now, but also hopefully. I think
how I feel right now.
I think for me is, like I said before, to be a bridge. So after my transplant, no other woman of African descent has gone through a clinical trial at the NIH without the provision of fertility preservation. So for me, that's a step in the right direction, but it doesn't end with us because I recognize the privilege that I have. My parents were able to let me get an education in the US. Not a lot of people in my home country have that privilege. And so with heavy is the head that wears the crown, right? And again, my life has meaning and purpose. And so until fertility preservation grants are available to women in countries where there's a high patient population of sickle cell disease, where, in my opinion, curative therapies and disease modifying therapies need to be actively taken to those regions. Until that is done, my work will never fully be done. Have I opened doors for women that come after me? Yes. But that's only, to me, we're only, like, scratching the surface there, because I just think there's so much work to be done, whether it comes to being on the policy side or on the healthcare side or on the research side. I think I will always actively figure out ways to be more inclusive for women, but also be a strong proponent of women, because again, I recognize that my story isn't necessarily unique to me. There are a lot of us within the sickle cell space that motherhood is something that's just part of our genetic setup of, like, what our ideal life is going to be and look like. And so by any means necessary, if surrogacy happens for me, fantastic. If it's adoption, fantastic. The family will happen. And if it doesn't happen, I have amazing children around me who will continuously pour into me. So either which way, I think we will win. And I say that for T and I, we will win. Either way the cards turn out. Yeah.
Thank you so much for that, Wumi. I want to ask two more questions. One is to Dr. Thomas, and then the last one will be to both you, Wumi, and Tiana. And I'll share the questions so you can have some time to think about it. What are questions or advice you can give to those living with sickle cell who are considering a transformative therapy, and they're also considering having biological children in the future? So that's the question. And Dr. Thomas, I'd just like to collect any parting thoughts from you.
Oh, I'm so full right now. Thank you for sharing your stories, both of you, and just this platform of vulnerability and honesty is so transformational for so many women. I can just literally hear the patients I work with in my mind, and I'll hold their stories visibly and invisibly with me. I guess I can close out, since we shared something vulnerable, is also that for me, when I was in Ghana, I was also dealing with fertility issues myself. I did have a pregnancy loss simultaneously during my collection of sickle cell data on the continent. And it was very, very, very challenging for me. I'm actually still going through grief therapy for it. And I'm still finding language to talk about it. So both of you giving me so much right now that it just makes me feel like I can share as well. Because standing on the front lines, doing this research as a maternal and child health scientist, so to speak, I'm working with a lot of patient populations, but simultaneously I'm a patient myself. And so I'm going to these spaces and listening to so many women's stories, but at the same time, I was losing my child, my pregnancy at the same time. And so being able to be stretched across like those intersections, it was very, very heartbreaking. So my heart breaks with both of you two in this moment. And I do believe that us sharing these stories is a part of the freedom and the liberation going forward. So that's my closing statement, is that we are here, we are open, and we are upholding each other so that we can continue to have groundbreaking moments to come on every level. So
that really got me. Like we've been like emailing back and forth, getting all excited for this presentation, and I had no idea.
I know. A lot of people knew, but
I'm so sorry. And I thank you for like trusting us and feeling like this was a safe space to share that. But I just want to commend you and thank you. Like, it's one thing for us to have sickle cell and be advocates, but for you to suffer that loss and still choose to do this work, that's like a really beautiful thing. So thank you for that.
Thank you. Thank you for saying that. I literally, yes, thank you. And we do this work because there are women and children connected to us whose names we may never know. So when I was writing the proposal to do this work, I had no clue that one of the patients on the way out, she's 13 years old. She has sickle cell disease. She handmade this bracelet for me in Ghana. And she said, Dr. Thomas, thank you for the swag project. Thank you for this. And I had no clue, like months before I even met her, that I would, be doing this work to meet young girls like that. So I'm saying that there's so many women behind us and in front of us, and they need us to be pillars. So that's what kept me going. Even though I was at a loss, it was seeing those faces and hearing those stories and saying, if we don't do this work, then who will?
Absolutely.
We'll just slip through the cracks, and it's not on my watch.
And your story and experience is what makes you perfect for your role in this and what makes you powerful in your role in this. So thank you so much for sharing that. I'll have Wumi go next on, what specific questions should people ask about, fertility preservation if they're looking to have biological children in the future, or what advice can you give?
First advice would be, if something is important to you, it should always be important to you. Don't let anyone tell you otherwise. I think it's vital that reproductive health is a conversation that we will continuously have so that more warriors, especially the younger warriors, are more informed. Because again, I have to think of warriors who can't speak for themselves or advocate for themselves currently, who are considering gene therapy and transplantation, who are under the age of 15 or 10 and haven't even started their period. I know for me with sickle cell, I was late to having my period show up. And so I can't imagine what my life would have looked like. My parents made the decision for me to embark on a curative therapy, but took away my ability to have children, I would never forgive them. So for me, for parents, I ask that not only do you do your research about the curative therapy process, but sit with your children and listen to them. I think it is such a big decision to make on behalf of someone. So have a conversation where if it means delaying the clinical trial or the curative therapy process so that everything can be ironed out, call in different stakeholders into that conversation so you make a decision that you can all live with at the end of the day, And I think if fertility preservation is what you want for yourself, nothing good in life comes easy. I hate to say that. And as Black women, there's a lot of onus, structural racism, institutional racism, economic issues, social issues, environmental issues that we're plagued with from the moment we take our first breath as babies. There's so much that's put on us. And so I hope that even with all of that stress and chaos, that you're able to, within yourself, find the strength to say, because I want this so badly, I will do everything within my power to make sure it happens. Financially plan. Everyone I recommend when they're going into the curative therapy process, I always say, have some fallback money, because there will be all kinds of miscellaneous costs that will come out. And I think if you are financially prepared, it doesn't make the problem go away, but it makes it relatively easier to navigate whatever hiccups you might encounter. So I say all that to say, because if I think to T's story and I could rewind the hands of time, I wonder that if she had funding for fertility preservation, if she wouldn't just have blindsided the team and preserved her fertility before even starting the process altogether. So again, as women, a lot is expected from us, but I genuinely think this curative conversation is not going to be applicable to everybody. Mm-hmm. It's not going to be available for everybody. Gene therapy is still in its research and trial phase. And so I'm just saying, think wisely before you embark on the curative therapy process.
I couldn't have said that better myself.
Right. I'm trying to sit here and figure out how to come behind that.
You always do a good job, T. And I just wanted to leave you with the last word in all of this, as our leader of SC Red. And please share with us what advice, what questions should people ask for when considering this, using your experience and experiences that you know of others?
Yeah, so I'm going to broaden it a little bit, because a lot of times and this is what I see a lot, SC Red, we've been all over the news lately about fertility preservation specific to gene therapy, but I want to just say that even outside of gene therapy, disease progression alone can impact fertility. Iron overload, we have data that it impacts thalassemia. We don't have it in sickle cell, but I can speculate that iron overload does too. There's some data about what hydroxyurea can do to sperm count and ovarian reserve, possibly. So we need more data, but I just want to say that there are going to be sickle cell warriors who will need access to fertility services, regardless of if they're pursuing a transformative therapy or not. And so I think if my legacy on this earth could just be that people were informed and aware of that one thing, I would be happy. So my biggest thing is to just stay informed. And I can't guarantee you that every doctor, every hematologist, every reproductive endocrinologist is going to prioritize your fertility, but I want you to do that. So when you're going into these appointments, if they're not bringing up your fertility status, you have to bring it up if that's important to you. And when we said, you can plan. And to answer that question, I did. That was the first thing I did when I got out of that consultation. I saw the cost and looked for financial resources. And what I just saw was a long list of foundations that would give away grants for egg freezing and sperm banking if you had a diagnosis of cancer. So when I started SC Red, that's all I thought we would do. I thought we'd just give away grants, and we expanded. But I think that's my biggest thing, is to just be informed. And when we said, if it's important to you, then advocate for that. And also follow us. Follow SC Red, because I'm really working overtime. Like I said, we have that partnership with Be the Mat, or now the National Marrow Donor Program, formerly known as Be the Match, where there is up to $10,000 allocated for fertility preservation. And I am working on that same thing. And I don't for gene therapy, but like I said, just anyone who wants access to these services, I am working on resources for that, both philanthropically and through legislation. And we've been working with CMS. So I don't know if everybody saw the announcement that came out that fertility preservation is included in that access model. And so now it's just a matter of seeing which states sign on to that. And I just thank everybody for being so gracious with me, because whenever we talk about this, I have the hardest time articulating myself. But I also want to just say that I really appreciate the three of you for sharing this space with me and for also keeping me accountable. Like, sometimes my lens is in the United States. And so I want to thank you for keeping me accountable that this is a global issue. And I don't know what it's going to look like yet, but there's definitely some type of global collaboration between the four of us. And I also want to just thank everybody for tuning in and for the beautiful comments. I'm getting emotional, so I'm going to stop. And Kaz, I'll let you close it out.
I just want to close out by reading some of these comments. Wow, both powerful journeys. Thank you for sharing. Somebody said they totally understand what you're feeling. I'm feeling so emotional and empowered right now by this conversation. You're all amazing and can definitely feel how passionate you all are. God bless you, ladies. And this one's my favorite. You have turned your pain into purpose, and it's such a beautiful thing. So I'll leave it at that. There are tons of other comments, but I'll leave it at that one. And thank you all so much. It's been such a pleasure to be on this panel with you, with the three of you guys, and just very, very much appreciate your expertise, your vulnerabilities, and your stories are really powerful to the group. So thank you so much.
Thank you. Oh, and I forgot to thank the sponsors. Let me do that because that's one of the benefits, and I will get in trouble. So CVS, Bluebird Bio, Vertex, and Pfizer, thank you for sponsoring. And I hope that everyone will join us on March 26th when we have Dr. Tisdale as a follow-up to the 60-minute special. There's been so many updates since we last had that 60-minute special. There's been 2 approvals and all types of announcements from CMS. So we're going to catch up with the man behind the science and get his initial reaction and see where he's trying to go. So thank you, everyone, for tuning in, and we'll see you next time.
Thank you so much.